The following podcast is part of a certified educational activity titled Emerging Options for Targeting PCSK9 in Hypercholesterolemia Management, Visualizing New Routes to Individualized Care. Access the entire activity and complete the post-test at peerview.com/CXZ860. Downloadable additional resources are also available.
Hello, I'm Dr. Mark Sabatine from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this visual exploration of emerging options for targeting PCSK9 in hypercholesterolemia management. For our goals for today, we want to augment your knowledge of screening and diagnostic guidelines for patients with hypercholesterolemia. We want to understand the mechanisms of action, the administration, efficacy, and safety of emerging agents targeting the PCSK9 pathway to reduce LDL cholesterol levels, sharpen your skills to identify appropriate patients who may benefit from intensive LDL cholesterol-lowering therapies, and then review the data for emerging PCSK9 targeting therapies. So let's start by discussing how we would overcome the barriers to CV risk recognition and intensive treatment. So if we think about the trends in cholesterol levels in the United States, we have indeed made progress over the years. We have data from a variety of national surveys like NHANES that have looked at individuals in the United States, aged 20 years or above, for over a decade. And in these surveys, we have made some progress in getting down average cholesterol levels in the country for both men and women. But if we look specifically at LDL cholesterol, while the levels have gone down a little bit, they're still too high, where the average levels are roughly in the 110 to 120 milligram per deciliter range. Now, why do we consider that too high? Well, we can see that elevated levels of LDL cholesterol increase the risk of incident cardiovascular events at any age. Whether one is young, middle-aged, or old, having a higher LDL cholesterol level increases that individual's risk for ASCVD, particularly for myocardial infarction. So this is a well-established risk factor that we want to reduce to prevent our patients from developing ASCVD and its complications. Now, when we think about a patient who might have hypercholesterolemia, there are a variety of reasons why. So if we think about our patients with hypercholesterolemia, there's really a gradient or a range. And behind all those different levels are different potential molecular etiologies. So at the top of the range are individuals who have homozygous familial hypercholesterolemia. These individuals have cholesterol levels that are typically north of 500, even 1,000 milligrams per deciliter. This is due to having a defective LDL receptor, and so having two either null or defective alleles or a compound heterozygote of one of each. And these individuals, because their cholesterol levels are so high, then manifest clinical atherosclerotic cardiovascular disease at a very early age, even in their teens. And you can move down one notch to individuals who have heterozygous familial hypercholesterolemia. These are individuals who then typically have one pathogenic variant, so one null allele or one defective allele, typically in the LDL receptor. This was the groundbreaking work done by Brown and Goldstein, but other genes and their proteins can also be a cause, including PCSK9. We'll talk about the biology of PCSK9 down the road, but individuals who have a gain of function mutation wind up having a phenotype of familial hypercholesterolemia. You can also have mutations in ApoB that can give you this phenotype. And these individuals typically have LDL cholesterol levels that are 190 milligrams per deciliter or higher, though some people can be a little bit lower than that. And then moving down is sort of the, if we will, kind of the common hypercholesterolemia. These are individuals who don't necessarily have a monogenic disorder. They might have it for so-called polygenic reasons, meaning multiple different variants, each of which has a relatively small effect on LDL cholesterol, maybe 5-10 milligrams per deciliter, but they happen to have the bad luck to inherited several of these variants, and that puts their cholesterol levels higher than the average person. And so these people will have LDL cholesterol levels in the 130, 140, 150, 160 milligram per deciliter range. Now, those are people who were unlucky, if you will, and got dealt a bad genetic hand in life, but the converse is also true. There are individuals who can inherit protective variants, including in the LDL receptor and for PCSK9. And so that's a story that I'll get to in a little bit more detail for the molecular mechanisms. But the genetic story is quite interesting in that Marianne Abifadel and colleagues were looking at families who had the phenotype of familial hypercholesterolemia. And so they looked to see if they had variants in the LDL receptor and the ApoB gene, and they didn't. And so the search was on to find the genetic locus explaining it in these families. And so they found variants in chromosome 1 in a gene called PCSK9 that no one knew what its link was to hypercholesterolemia. And it was only after the biology had been sorted out that it turns out that these individuals had gain-of-function mutations. And so then researchers hypothesized that if a gain-of-function mutation in PCSK9 caused high LDL cholesterol levels, then could we find the converse of that? Could we find individuals who had a loss-of-function variant, and might they have lower LDL cholesterol levels and be protected from coronary disease? And that's exactly what individuals found, looking at a variety of databases, and that then suggested that PCSK9 could be a druggable target. And so while we've talked about then the molecular underpinnings, then as you can imagine, there's also a gradient of coronary artery disease risk. So that the higher the LDL cholesterol, the higher the risk of coronary artery disease. And so as we think about the prevalence of these various disorders, we could think about the genetics in terms of familial hypercholesterolemia, where that is around 1 in 300 or so in the general population, so more common than people might realize. But certainly in patients who have ASCVD, then it's more common, about 1 in 17 or so. So that's a little bit for the LDL cholesterol levels and the genetics for it. How do we recognize individuals who are then at very high risk? So the U.S. guidelines speak to this with a very high risk category defined as either individuals having more than one major ASCVD event or one major ASCVD event and multiple high-risk conditions. This nomenclature, this approach was taken from the 4A trial, which we led, in Odyssey Outcomes that use these as enrollment criteria. So, what is a major ASCVD event? That was recent ACS within the past 12 months or history of MI. Obviously, there's an overlap between the two. Anyone who's had a recent ACS by definition has had a history of MI. So basically a coronary event, an MI, or a cerebrovascular event, a history of ischemic stroke, or symptomatic peripheral arterial disease, typically defined as either a history of claudication with a low ankle brachial index. 0.9 is typically what's used to diagnose PAD in the clinical trials. Just to make sure we have the right population to increase specificity, we've used 0.85. Or they've had a previous revascularization or amputation. So those are the so-called major ASCVD events. And then the high-risk condition would be being age 20 or above with any of the following. And there's sort of a long laundry list here, but it's very high levels of LDL cholesterol level, greater than 190 milligrams per deciliter. As you recall, that's the level where we start to think more and more that this person could have familial hypercholesterolemia, if they indeed have a diagnosis of heterozygous familial hypercholesterolemia, if they've had a history of coronary revasc, a CABG or a PCI, if they have type 2 diabetes, hypertension, CKD, current smoker, or, and those are all the classic ASCVD risk factors, or if they have an LDL cholesterol that's 100 milligrams per deciliter or higher, despite being on maximum statin therapy. That's also a high-risk group. And then patients with a history of heart failure are also just at higher risk for cardiovascular events. All right, so now let's think about the targets we want to have for our patients and the data supporting those targets. So these are the data from the U.S. guidelines, the AHA-ACC guidelines. They came out in 2018. The European guidelines, which I was a co-author on, came out the following year in 2019. After our 2019 ESC guidelines, the AHA guidelines kind of moved in lockstep with that and issued an update with an expert consensus decision pathway. So not technically a guideline update, but that sort of aligned the U.S. recommendations better with the European ones. In both sets of guidelines, in both sides of the Atlantic, the notion is you figure out what risk bin the patient falls into based on a variety of risk calculators or sort of a menu of qualifying features. And then based on what risk bin they're in, that determines what your goal is for those individuals. But I'm going to stress the commonality that for individuals who are at very high risk, and we covered what that means. So people have had typically a major ASCVD event, for example. The goal for those individuals is to have an LDL cholesterol. Previously in the U.S., it had been under 70. In the European guidelines, we chose under 55. And then the 2022 expert consensus decision pathway then mimicked that and also recommended getting the LDL cholesterol under 55 milligrams per deciliter, right? And we'll see that even though those guidelines have been in place now for multiple years, we have not been doing a very good job getting our patients to those levels. There's also recommendation that there's at least a 50% reduction from baseline. And then if the risk is less for the individual, then the targets, then they're a little more lax for that. So instead of getting down to 55, you just need to get under 70. And if your risk is even below that, you can be under 100. And we'll talk about those risk bins and how you fall in there in a minute. But to also note that there's a very high risk group that we identified in the European guidelines for people who have recurrent vascular events despite being on maximally tolerated statin therapy. If those people are still having events, their LDL cholesterol needs to be even lower. And for that group, we suggest that you can consider a target of under 1 millimole per liter or under 40 milligrams per deciliter. And so this here graphically depicts sort of a bullseye here that as the risk goes up, you move more into the center of this graphic and the targets become more and more intensive. And so in the sort of primary prevention arena, or people who have type 2 diabetes, or people who have a CAC under 100, you might have an LDL target of under 100. Then in the European guidelines, if you do have diabetes and your 10-year risk puts you into a higher risk bin, or you have evidence of coronary disease with a CAC score, coronary artery calcification score of at least 100, then your target moves to less than 70. And then patients who we see as cardiologists who are very high risk. We've talked about those individuals. They've had an MI, they've had an ischemic stroke, they have PAD. Right, those are people who then we're targeting an LDL cholesterol under 55 milligrams per deciliter. And as I mentioned, those who are very high risk, who are having recurrent events, even more aggressive target of under 40. Now, what are the data supporting these aggressive targets? Well, I'm sharing with you here some data that we published from the Fourier trial. That was a randomized trial, about 27,000 patients of evolocumab, a PCSK9 monoclonal antibody versus placebo. We'll talk more about the trial in a little bit, but I'm going to give you a snapshot here just as a foundation for the targets and the guidelines. There was a subset of individuals in that trial who got in with an LDL cholesterol under 70 milligrams per deciliter. That had been the prior target, in fact, when the U.S. guidelines had come out. Just get the person under 70 milligrams per deciliter, and you're okay. You don't need to do anything more for that. Well, in the 2,000 patients in Fourier who entered with an LDL under 70, where the U.S. guidelines previously had said you don't need to do anything, you can see that adding a PCSK9 inhibitor reduced the LDL cholesterol levels down from a median of 66 milligrams per deciliter down to 21 milligrams per deciliter. Amazingly low levels. Now, the question is, was there any clinical benefit for this group who many would consider already at goal? Was there a benefit for getting their LDL cholesterol down? And the answer is yes. And you can see that on the two forest plots. The upper one is the primary endpoint. The lower one is the key secondary endpoint. And for the subgroup of patients who had an LDL cholesterol entering the trial under 70 milligrams per deciliter, that they benefited just as much, if not more, than those who came in with LDL cholesterol levels that were higher. So a 30% reduction in the secondary endpoint, which was a composite of CV, death, MI, or stroke, 30% reduction for getting that LDL cholesterol from 66 milligrams per deciliter down to 21 milligrams per deciliter. So should we treat these people even if their LDL is under 70? The answer is yes, we should. And so this gives you a sense here of the options available as you're targeting LDL cholesterol for your patients. Obviously, statins are the foundational therapy, and high-intensity statins should achieve about a 50% reduction in LDL cholesterol on average. And here we show a variety of other currently approved medicines. Ezetimibe for the oral medicines has been around the longest for that. That reduces LDL cholesterol by about another 25% or so. A newer kid on the block is bempedoic acid, which lowers LDL cholesterol by about 18% or so. And obviously then there is a fixed dose combination of bempedoic acid and ezetimibe, which then together, as you would expect, then gets LDL cholesterol down by about 35 to 40%. Then as we move to the right, we have the injectables. And so starting at the far right is probably the most potent combination, which is evolocumab, given at 140 milligrams every other week or 420 milligrams monthly. And that can achieve LDL cholesterol reductions of about 65%. Alirocumab, 150 every 2 weeks, is pretty close to that at 62%. It can be given at a lower dose of 75 milligrams every 2 weeks, and then not surprisingly, the efficacy is less. And also the monthly dose, the efficacy is more on the 50% range. And then inclisiran, and we'll talk about how that injectable works. It's not a monoclonal antibody, but a small interfering RNA. That achieves also about a 50% reduction in LDL cholesterol. There's cardiovascular outcomes data for all of these, save for inclisiran. And we, in conjunction with Oxford, are doing one of the two big cardiovascular outcomes trials, Orion 4. The other one is Victorian 2P. And so we hope to have cardiovascular outcomes data in the next several years. But we do have outcomes data for evolocumab and alirocumab, as well as for ezetimibe and bempedoic acid. So, but just to remind people, of course, as I said earlier, statins really are still the foundation for lipid-lowering therapy. They are highly effective both in primary prevention and in secondary prevention, large risk reductions. Obviously, the magnitude of the risk reduction depends on the LDL cholesterol lowering, but we know that there is roughly a 20 to 25% risk reduction for each millimole per liter, or roughly 40 milligrams per deciliter, that one lowers a patient's LDL cholesterol levels. And we also know that these drugs are, in general, extremely well tolerated with really minimal symptomatology. All right, so we have these great therapies available, and yet despite that, we as a medical community are not doing a great job getting our patients treated and getting them to goal. And so if one thinks across the entire spectrum of patients with atherosclerotic cardiovascular disease, and we use even an older goal of 70 milligrams per deciliter, right now out of date, 55 is what we should be using. Amazingly, about 3/4 of patients are still above that 70 milligram per deciliter goal. So we're not getting people down to where they should be. If we look at the subset of people who are high above the goal we want them to be at, we see that about half of them aren't getting lipid-lowering therapy. So, I mean, that is truly kind of the low-hanging fruit there, that these individuals need to be put on some form of therapy. All right, statin obviously is foundational therapy to start getting their LDL cholesterol down, and then obviously additional therapies as needed. Now, this is for sort of the run-of-the-mill patient we talked about, but we also want to keep in mind about heterozygous FH being relatively underdiagnosed and undertreated. And the National Lipid Association did a survey now several years ago from both primary care physicians and cardiologists, seeing if they could correctly diagnose heterozygous FH from a case vignette. Cardiologists did a little bit better at 57%, primary care physicians at 43%, but one would really hope those proportions would be higher. Right, these are patients who need intensive lipid lowering. You don't want to miss diagnosing such a patient. And then when you ask individuals, have you ever diagnosed a patient with heterozygous FH? There's a substantial number who have never seen someone with FH, and yet we know, given the prevalence, that these patients are out there. So this just speaks to the relative underdiagnosis for that. And then how many would refer a patient with heterozygous FH to a lipid specialist? Very few. less than 10%. Now, I guess if the patient had their LDL cholesterol well controlled with the medicines, you wouldn't necessarily need to do that. But given that we saw that their ability to diagnose these patients is minimal, and that most have never even diagnosed a patient with heterozygous FH, it's sort of worrisome that these patients are not being plugged in for the care that they would need. And noting that even though these individuals have high levels and typically need, in addition to a statin, aggressive non-statin therapy, that amongst primary care physicians, half have never prescribed a PCSK9 inhibitor to the patients they have with a heterozygous FH, and a third of cardiologists haven't done so. So as we think about the gaps in dyslipidemia care, clinicians and other healthcare professionals who care for patients with hypercholesterolemia frequently encounter challenges with applying the treatment guidelines for both primary and secondary prevention of CV events. Statins are not necessarily effective in achieving lipid goals in everyone. Patients who are eligible for or may benefit from a PCSK9 targeting therapy are frequently not identified and consequently undermanaged. And even if they are prescribed a PCSK9 inhibitor, there are issues for access, perhaps intolerance to the injection site reactions, all of which slowly add up to our patients not getting the LDL cholesterol treatment that they need. What are the routes for individualized hyperlipidemia treatment? So in the guideline for both the ACCHA guidelines as well as the recent expert consensus decision pathway, that they acknowledge the addition of PCSK9 inhibitors for high-risk patients, right? So very high-risk patients with ASCVD, if they're not at goal. And as we discussed in the update, that goal now is an LDL cholesterol under 55 milligrams per deciliter. That if they're not at goal, then you need to add something else to get your patient to goal. And so the preferred limb is then adding either ezetimibe and or PCSK9 inhibitor monoclonal antibody. Those are the preferred agents because we have cardiovascular outcomes data showing the benefit. We did the Improve It trial with ezetimibe showing the clinical benefit for it. And we did Fourier with the PCSK9 inhibitor evolocumab, one of the monoclonal antibodies. So there's data supporting that for a reduction not only in LDL cholesterol level, but most importantly, reduction in cardiovascular risk. Which of those two you might give will, of course, depend on the patient in front of you and what their LDL cholesterol is while they are on the maximally tolerated statin therapy, what your goal is, and so how much additional reduction you need. And so if you think you can get them to where they need to be with only a 24% reduction, and ezetimibe might be a reasonable option. If that's not going to get them where they need to be, then obviously you need to give them something more potent, and you can give them a PCSK9 inhibitor. Now, since this came out, we do have some data for bempedoic acid, albeit largely in statin-intolerant patients, but we did see a reduction in cardiovascular events there. And as I mentioned, there's 2 ongoing trials, large cardiovascular outcomes trials, looking at the benefit of inclisiran in patients with ASCVD. Now, as we think about the mechanism of action for the different approved lipid-lowering agents, we have a lot of different drugs. I'll start with the statins since they are foundational. They will interfere with the internal biosynthesis in cells of cholesterol. The cells, sensing that they have a lower intracellular cholesterol level, will attempt to rectify that by upregulating synthesis of the LDL receptor. Those LDL receptors then go to the surface of the hepatocyte, and as the blood is going by, LDL particles, which are cholesterol-rich, LDL particles will bind to that LDL receptor and be internalized. Now, we also have ezetimibe that reduces cholesterol absorption, but that triggers the same sensors in the cell, in the hepatocyte, that it is relatively low on cholesterol levels, and that again leads to upregulation of the LDL receptor and clearing more LDL and therefore more LDL cholesterol out of the circulation. Bempedoic acid also works in that same biosynthetic pathway for cholesterol inside the cells, but at a slightly different point for it, but results in the same thing, lower intracellular levels of LDL cholesterol and therefore upregulating the LDL receptor. Now, let's add another level of complexity here. When that LDL receptor is internalized with its payload of the LDL particle, that cholesterol-rich LDL particle, typically then that dissociates. And the LDL receptor, as you can see here, can recycle back to the surface of the hepatocyte, free to then take additional LDL particles and their cholesterol out of the circulation. Now we're going to add in PCSK9. Those are also secreted by hepatocytes. They then bind to the LDL receptor. When then that LDL receptor binds to an LDL particle and it is internalized, instead of the LDL receptor being able to disassociate and go back to the surface of the hepatocyte, it is stuck in its conformation there with the LDL particle, and then it is trafficked to the lysosome, where both the LDL particle and the LDL receptor undergo degradation. And therefore, the LDL receptor cannot return to the surface and cannot remove cholesterol from the bloodstream. And so we see there are a couple of ways of inhibiting it. Here is the monoclonal antibody binding to and thereby inactivating PCSK9 so it can't bind to the LDL receptor. We also show inclisiran coming in, and we'll go into more detail in a minute, that works as a small interfering RNA that blocks the production of PCSK9 in the hepatocyte. This is just a more detailed view here of the PCSK9 monoclonal antibodies binding to the PCSK9 and preventing it from interacting with the LDL receptor. So now you can imagine what I mentioned earlier on, that when they found those families that had the phenotype of familial hypercholesterolemia and they found mutations in the PCSK9 gene, ironically, what they found were gain-of-function mutations. So these individuals had too much PCSK9 around. That PCSK9 was binding to the LDL receptors and taking them out of commission. And therefore, these individuals couldn't clear the LDL particles out of their circulation, so they had high levels of LDL cholesterol in their bloodstream. That then led researchers to think, I bet you we could find individuals who have not gain of function, but loss of function, and those individuals should have, therefore, lower levels of PCSK9, more LDL receptors can go to the surface of the hepatocyte, they can clear more cholesterol out of the circulation. These individuals should have lower levels of LDL cholesterol. And that's exactly what Jonathan Cohen and Helen Hobbs at UC Southwestern found in a particular cohort for individuals whose LDL cholesterol levels were more like the 70 milligram per deciliter range. And this just shows data from the 4A trial. This was, as I mentioned, a large trial we did, enrolled over 27,000 patients with what we would now describe as major ASCVD event, prior MI, prior stroke, or PAD, an optimized statin therapy. You can see on the left that the addition of evolocumab reduced LDL cholesterol by about 60%, down to a median level of 30 milligrams per deciliter. Right? I suspect that is lower than the levels that you're able to obtain for the vast majority of your patients in clinic who are just on, for example, statin therapy. And then you can see on the right that translated to a reduction in major adverse cardiovascular events, a reduction in the primary endpoint of 15%. That's a composite of cardiovascular death, MI, stroke, unstable angina, or coronary revasc, and a 20% reduction in the composite of CV death, MI, or stroke. Similar data for alirocumab, another monoclonal antibody, again, reducing LDL cholesterol levels, in this case by about 50 or 60% or so, and again, a 15% reduction in major adverse cardiovascular events. So very compelling data validating PCSK9 as a target, that knocking down levels of PCSK9 leads to lower levels of LDL cholesterol and lower risk for major adverse cardiovascular events. There have been a variety of other trials done. This was a smaller trial, EVOPAX, just showing that in your patients coming in with ACS, that if they are just treated with atorvastatin that was sort of standard of care, atorvastatin 40 milligrams daily, versus atorvastatin plus evolocumab. And we look here at the LDL cholesterol levels, not surprisingly, much lower in those who had evolocumab added. But this is the important point here, that if you look at achieving goals, and on the left-hand side, we had what the older U.S. goals were, on the right-hand side, now the European goals and the more recent goals elaborated in the 2022 update in the U.S., that with statin alone, you don't achieve that goal in the vast majority of individuals. But you add a PCSK9 inhibitor and you achieve that in 90 to 95% of patients. Now, what about safety? And these are data from Fourier and Odyssey outcomes, and you can see that the rates of adverse events, serious adverse events, were the same in either the monoclonal antibody or the placebo arms for both of them. No difference in allergic reactions. As you might expect, though, for an injectable drug, there is an excess in injection site reactions, only 0.5% over a median follow-up of 2.2 years with evolocumab, a little bit more of an excess with alirocumab, 1.7% over median follow-up of about 2 3/4 years. But if you look at adverse events that led to discontinuation of study drug, no difference between the two arms. And then for the side effects, rightly or wrongly ascribed to statins, no difference in myositis, no difference in elevated aminotransferases, no difference in cataracts, no difference in new onset diabetes. So overall, PCSK9 inhibition is a very safe approach to lower LDL cholesterol, and the monoclonal antibodies look quite safe, the only side effect being really injection site reactions. Now, we've talked about the monoclonal antibodies. Here, I want to show you data for inclisiran, which is a small interfering RNA. This is a very nice graphic here really showing how siRNA works. And here we have that same biology of the hepatocyte with the LDL receptors there taking LDL particles into the hepatocyte. What we've added into this now is this small interfering RNA. It's a double-strand nucleotide compound that is conjugated to a GalNAc moiety. That just enables it to be taken up easily and preferentially by hepatocytes. Once it's into the hepatocyte, there are two strands there. One of the strands, the guide strand there, is the mirror image, if you will, of the mRNA, the messenger RNA of interest. In this case, it is the complementary strand for the messenger RNA for the PCSK9 gene. And so you can see that then that target, that guide strand, binds to the messenger RNA for PCSK9. Cells have this risk complex that basically, when it's loaded with this guide strand, looks for targets that match, in this case, the mRNA for PCSK9, and chews it up. That's degraded. That risk complex can actually recycle and degrade other messenger RNA transcripts for the PCSK9 gene. And by doing so, then you are preventing the synthesis of the PCSK9 protein. Therefore, by doing that, then if you don't have as much PCSK9 protein there, then the LDL receptors aren't chaperoned to their death, and they can continue to be recycled and take LDL cholesterol out of the circulation. And in trials, it looks like inclisiran reduces LDL cholesterol by about 50%. It's given an initial dose, another one at 3 months, and then every 6 months thereafter. The side effect profile for inclisiran also looks very good, with really no differences in adverse events or serious adverse events, no difference in diabetes, aminotransferases, elevations in creatinine, elevations in creatine kinase, no thrombocytopenia. Again, it's an injectable, and so there are increases in injection site reactions, the vast majority of them being mild in nature. And yet, despite these drugs that we've seen in the randomized trials are well tolerated, when one looks at how well patients are actually treated with them, we see that despite being prescribed them, that the time to discontinuation, that you have probably a quarter or so of the patients who are prescribed a PCSK9 inhibitor coming off the drug in the first 3 months or so. So we may be writing these scripts, but if our patients aren't able to take the drug for a variety of reasons, then they can't see the benefit of them. So what are the barriers to PCSK9 inhibitor use? Well, for the monoclonal antibodies, you need to inject every other week or monthly, but that winds up being a whole bunch of injections. The small interfering RNA is in steady state just 2 injections a year, but they're still injections. Some patients would prefer to inject themselves, but then you need to inject yourself every 2 weeks. The small interfering RNA currently can only be given by a healthcare provider, so you need to come into the hospital to get that injection. Again, some people might prefer that, but it entails the, if you will, the inconvenience of having to come into the hospital. Both of these wind up being quite expensive. So those are the challenges, the barriers for use. What are other options out there? Here, this just shows a partial list of other drugs there. And what we're going to focus on in particular is an oral drug, a macrocyclic peptide that can be given once a day. Other options there are other injectable options which can achieve reductions similar to what you can with the PCSK9 inhibitor. There's gene editing therapy, but that remains still highly in the experimental stage and very avant-garde technology.
In normal physiology, low-density lipoproteins, or LDL, bind to receptors on the surface of hepatocytes and are internalized. This removes LDL from circulation along with the atherogenic cholesterol it carries. The receptor then recycles back to the surface of the hepatocyte to clear more LDL. PCSK9 is a protein secreted by hepatocytes that can also bind to the receptor, but this causes the receptor to be destroyed when it is internalized. Current strategies to block this process and make more LDL receptors available include monoclonal antibodies, which bind to PCSK9, and small interfering RNAs, which reduce production of PCSK9. Both agents reduce circulating LDL-C levels, but they are administered by injection. Small molecules can be taken orally. But ones that prevented PCSK9 from binding to the LDL receptor could not be developed. Recently, a macrocyclic peptide was developed that can block the interaction between PCSK9 and the LDL receptor. This new PCSK9 inhibitor is taken orally and reduces LDL-C levels to a degree similar to current injectables.
So we've heard now a little bit then about this new drug, MK0616, that really the medicinal chemists working on it were able to figure out what was thought to be an untractable problem. How do you create a relatively small molecule compared to a monoclonal antibody that could possibly bind to this sort of broad, flat face of PCSK9 as it binds to the LDL receptor? And they were able to find such a compound that does successfully bind to PCSK9 and prevent it from binding to the LDL receptor. And we have some nice data. These are data presented by Christy Ballantyne and published in JACC last year in a dose-ranging trial showing that at doses ranging from 6 up to 30 milligrams per deciliter, that MK0616, a pill just taken once a day, can achieve LDL reductions compared to placebo that are comparable to what can be achieved with the monoclonal antibodies and slightly better than what can be achieved with inclisiran. So, on the order here of a 55 to 60% reduction in LDL cholesterol. The results, these are the overall results, as we would expect, look very consistent across all different sorts of subgroups based on age and sex, etc. Adverse events overall were no more common with MK0616 than they were with placebo. So as we think about the different classes, we have probably the best established is in the middle, the monoclonal antibodies, where they can reduce LDL cholesterol by, with the highest doses, about 60% or so, but it does require injections every 2 weeks to 4 weeks. Most patients do the every 2 weeks, and therefore there's a risk for injection site reactions. Inclisiran achieves a little bit less, about 50% reduction in LDL cholesterol, only in steady state injections twice a year every 6 months, but you need to go into a healthcare provider in a clinic someplace to get the injections. We do have data for cardiovascular risk reduction with the monoclonal antibodies. The trials are ongoing, as I mentioned, for inclisiran. The cost for both is relatively high, though. And then, as I mentioned, the new kid on the block, still experimental, is the macrocyclic peptide MK0616, which looks like it can achieve comparable LDL reduction, but just as a pill that can be taken once a day. And we'll see what the side effect profile looks in terms of any GI side effects for it, and those will be determined in the ongoing phase 3 trials. And so as we think about it, really an interdisciplinary approach, we hope will improve adherence. I think for a patient with dyslipidemia, you need to have all the stakeholders involved, cardiologists, endocrinologists as needed, nurses, pharmacists. That can certainly help improve the diagnosis of dyslipidemias. You need to really come up with a individualized treatment plan based on the patient's risk and what their LDL cholesterol is, and figure out what combination of drugs one needs to give to achieve the appropriate LDL cholesterol goal. And there needs to be a conversation with the patient for which sort of drugs they like to take in terms of pills or pills and injectables. And as we think about improving adherence to lipid-lowering therapy and getting to goal, so certainly systematic screening of patients to identify those who need to be treated. Once the therapy has been initiated, one of the things we found is in some ways get the physicians out of the loop for the routine care. Physicians are busy. It's hard to schedule visits. You can really scale up one's ability to get to LDL goal by having a pharmacist-led, physician-supervised up-titration of therapy, because it can really be quite algorithmic, and the drugs in general are very well tolerated. And so we really have the tools at our disposal to do a better job for getting better control of LDL cholesterol level. And it's just a question of implementing them and having an experienced team. And at least for some of the newer kids on the block, there can be barriers to prescribing, and the paperwork can be one of them. And having an experienced team that can handle the documentation needed for prior authorization can make for a better experience for all. And so just some final key takeaways. So hypercholesterolemia is common, it's underdiagnosed, and it is undertreated. The LDL cholesterol goals have become more stringent, appropriately so, because we know that we have continued benefit dropping that LDL cholesterol from 100 down to 70, down to 55, and even in some individuals down to 40 milligrams per deciliter. Statins, while they're certainly the foundational therapy, equally potent are the PCSK9 inhibitors, and are really becoming the second-line therapy to then add on to get to these very aggressive goals. But it has been challenging having the appropriate uptake. There's a variety of reasons for those challenges, some of which are financial, some of which may be that they're injectable, and both physicians and patients may have less comfort in that. And emerging oral PCSK9 inhibitors appear to be a highly effective means for lowering LDL cholesterol. By definition, they eliminate injection site reactions. We hope that will lead to improved adherence, and there are ongoing phase 3 trials looking at and defining then the LDL cholesterol lowering in a larger population over a longer period of time, as well as an ongoing cardiovascular outcomes trial that we are leading. So that ends our discussion for today. I hope you found the activity informative and useful to your practice. Please don't forget to download the practice aids and slides for this activity by clicking on the appropriate icons in the menu at left. And I thank you very much for participating.
Thank you for listening. Remember to download materials and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Co, Incorporated. To access all materials for this activity, visit peerview.com/CXZ860.